Hello, and thank you for logging on to the Foundation for Physician Advancement podcast channel in partnership with Convey Med. FPA is a nonprofit built for and run by Marnie Reed and a group of dedicated physician educators. Our mission is to help physicians build a successful practice in today's healthcare setting through the development of your leadership skills and business acumen. I'm Marnie Reed, Executive Director, and we hope you enjoy today's discussion. This episode was recorded live at one of our Building a Successful Practice courses, so please pardon any background noise and conference references. This episode features moderator Dr. Michael Bolognesi leading a discussion on value-based care and advocacy with faculty Dr. Brian Culp, Dana Jacoby, CEO of Vector Medical Group, and Dr. Megan Wolf.
So with that, I'm going to start some questions.
So what you're saying a lot of the care for, and we have not just arthroplasty, right? There's sports, there's hand, there's a little bit of everything. And although arthroplasty has kind of been the forefront of these battlegrounds a little bit in the bundled world, it's coming for all of you, unfortunately, right? Centers of Medicaid Innovation, they've basically stated this is where we're going in a large percentage fairly soon. So it's good to start thinking about it now. But what does that mean? To your point, a lot of the care is preventative, and we don't have an incentive currently to do that, right? I get cortisone shots and gel shots or whatever. I send someone for an MRI, I get a PT. The bundles all favor me to do things that cost money. And we're now showing that, like as you asked earlier, shouldn't someone be trying to solve this problem rather than private equity? It should be us, right? We have to figure out how to cut our own fat if we want to continue to drive the boat. Is it education? Is it If you're a hand surgeon, are you teaching your patient better ergonomics so you don't get carpal tunnel typing on a computer? I don't know. But we have to be the ones driving the musculoskeletal care. And yes, we'll probably have to operate less, but there'll be plenty of patients to operate on, so it won't be a problem. But the whole point of this is, just like you're learning the vocabulary in this room, and you're learning about private equity, and you're learning about, you have to, you're running a business, we're running the business of the country of medicine, and we as the physicians need to be part of it. So the reality is, I don't know if I directly answered any of the questions, but my point is, it's important that we're all the ones making those decisions, because really we're the ones with the patient's best interests in mind. That's where we are.
Yeah, Carl, I will say, so for that one payer bundle that's hip, knee, and shoulder, so the margin, a portion of the margin goes back to our division to cover our costs. So that's how that's done. We can't go directly to the surgeon based on the care they delivered, but that money does come, you can say, look at our profit and loss statement, that comes back to cover our costs if we have deficits or whatever, to make sure people are paid. I suspect in a different environment, like not Duke Orthopedics or whatever, you probably could have a situation where it actually is more directly comes back to the physician, like a private practice. I'm sure it's easier to do. All right, other questions? Yes, Springer, please.
Paul, I have a question maybe just for the group. Is can you define for them what risk is, what assuming risk is in these models? I mean, right, fee-for-service has no risk, right? But these models, you mentioned it a lot, have varying levels of risk, and there's upside, downside risk. I think just for the people in the room that maybe aren't familiar with that, because those are terms you're going to have to learn as you start thinking about these.
Brian makes a great point, and I probably should have said it when I showed you that one slide from that one payer. We actually have what's called downside risk. Okay, so basically, that one is if we do have something, like literally, if we had something sort of go sideways, we're not at risk. But to Brian's point, there are situations where that would come off as a negative if you had a big outlier. We call them outliers, like the total episode of care. The cost was so high such that it created a deficit. That can happen. It depends upon the agreement. That one I showed is no risk, basically. So you could say, well, we're only going to get the upside. The upside means that, if we make margin, we get it. And you would say, well, why does the payer do that? The reality about why the payer does that is that what we've done probably by controlling the cost for the majority of the patients is still an advantage to the payer. So does that answer that well enough, you think? Yeah. Other questions? Oh, yeah. Another one. Neil. It's coming to spine, man. Don't worry, it's coming.
This is great, and it is coming to spine, right? If somebody gave me, 1,000 patients with back pain and said, you have $200 to manage each one, I would love it, right?
Yeah,
because
I know. Yeah.
Most people get surgery they don't need in spine. But my point, what I wanted to say about what you guys said is so a large primary care group there's a large primary care group in our area that refers us patients.
Yeah.
And then a few years ago, they started doing more and more of basically taking on risk, managing the population, gain sharing with the insurance company. And now they don't want to send us patients for surgery because we operate on those patients and then their cost goes up. So you just have to think about it that way too. As you said, someone has to manage these issues, these chronic musculoskeletal issues, and if somebody else who doesn't really understand that sometimes surgery in the long run is actually less expensive and better for the patient, if we don't get involved in managing it, then we're going to lose out to people that don't understand all the options for the patient as well.
Yeah, no, and again, so sort of a scary point, Neil, completely in agreement. When there are these stakeholder calls about like sort of a knee arthritis longitudinal bundle, it is heavily represented by, there are lots of representation from primary care folks that are dying to take this risk on. I mean, and so I'm just telling you, like, someone will take the risk on for this approach, whether it's back pain or whether it's knee arthritis, hip arthritis, shoulder arthritis. So understanding that you should be the entity making that decision is really important because it is it's real and it's coming and someone's going to do it. Okay, it's going to happen. Rich, you look like you got it. Go, buddy.
Oh, I just want to. I think getting involved when you start, right?
Yeah.
Like, it doesn't have to be on the hill with those guys. Also, what Bolo's saying is so important, and we've been doing this for a while now. And just to be at the seat of the committee in your hospital, right? You don't have to be at big fancy academic place. All of us individually, when we have jobs, we should be at the table, right? That's one of the things I've learned from these guys over the years is it doesn't matter how young you are, it doesn't matter, where you are in your life. It's something that's important for us to drive it. Because if you're not there, and you start small, right? Because you can't do all the big stuff right away. It just ends up being whole lot better for us. So when you start your jobs, you volunteer for a committee that you're passionate about. I know Brian's on like 90 or something like that. I don't know how many you're on, but that's where you start, just to understand the vernacular and just to be in the room, and then you really just take it from there. But I think that's I took the advice that you guys gave, and then when I went home a few years back, that's when I asked my chairman, like, hey, listen, how can I help? Being at the table on various committees, like unburden your kind of load as well. And I'm just learning and getting better. So don't be afraid to start right when you do it, because everyone in this room is very talented, hardworking, and intelligent. When you finish your training, it's actually kind of cool to watch where your minds can go now, right? The gates open. So it's never too early to start at that level.
I want to add a caveat to that.
Yeah, go, Megan.
So not only should you be in the committees, you shouldn't be afraid of going to the White House early on.
Yeah.
Because they don't care who you are. Yeah. They don't care that you're some big name orthopedic surgeon. They're going to care that you helped support them whenever they were doing the state Senate seat before they went to the Senate. And so so if you start when you're first into practice, when you're a resident, that's when they're going to get to know your name. You're going to get to build relationships, and then they'll actually listen to you. Otherwise, if you just go to the White House once a year and then you say, I want this, I want this, I want this, they're like, oh, okay, cool, see you later. You gotta actually build relationships, and that's when they'll start listening to you. That's when they'll call you and they'll say, hey, this is coming up. What do you think about it? And that's where you're gonna get the seat at the table. So I would say, yes, you should be on the committee, you should be doing this, but you should also be building these relationships in DC or at your local local senators, state senators, state house representatives, et cetera, even in your local city, because those people may build up, and then you'll have that relationship early on.
Megan, so I was actually going to ask you this, so I'll put it by. It's sort of similar to what you just said, but like just because I get asked this a lot, like, what do you do to get involved in advocacy, right? So like I can tell people, well, at AUKUS we go to the Hill once a year, like you're saying, but like maybe speak a little bit about your specific, because I know it's a passion for you. So like, what is that? What was the reality of how you did that?
So I actually.
And how long ago? Right?
Yeah. So I started second year residency.
Yeah.
I started getting involved in the Connecticut Orthopedic Society because that's where I went to residency. And then I learned about the NOLC where you went to the Hill once a year. And I went there, and then I was like, oh, this is really cool. How do I get involved earlier and doing things like that? And so getting involved with your local orthopedic society or your local medical society And they always have events going on. So I'll just get a message from the lobbyist and be like, hey, this congressman is doing this here. Can you go there? And it's like at someone's house, and you get to talk to them for 30 minutes. And like, I talked to one of the congressmen about yoga for like 30 minutes. And it's just building relationships. And so I think that, one, learning about the process early on, understanding what that means, getting involved in your orthopedic society or your medical society, and saying that you're involved, that you're interested. And the people who are most interesting in your societies are the lobbyists, because that's the ones that are going to be able to know what's going on and what, how you can get involved. So whenever I was in the Connecticut Orthopedic Society, actually before COVID happened, I started setting up something, and then it fell through because of COVID. Like, I got the lobbyists to get the residents together so that they could learn about how a bill is passed and how this works. Because before you go up there, you're like, oh, people are just making decisions. You don't realize, like, how is this developed? How does this pass hands? There's like 5 bills that mean different things, but that say the same thing. And so, like, understanding what that means, and I think that sitting down with your lobbyists to learn that, and if you're interested in doing that, I think setting that up is really interesting, and getting started early and learning that is really important.
Culp, you were a health policy fellow, right? So maybe speak to that experience and opportunity.
Yeah, so
interest.
It's purely something because I needed to learn. I didn't do it in residency, and I didn't know anything about it, and I wanted to do something. So, you know, just going to Washington D.C., as you said, it's a mind-numbing experience. But just to go back a step, some of you may be interested in research. Some of you may be interested in just taking care of your patients, and this isn't, you don't want to carve out time. Maybe you don't want to go there, and that's fine. There's other ways to get involved, right? You can donate to our PAC. There's lots of other groups like podiatrists and other people who are way better organized, dentists. They're way better organized as a group. We all like fight against each other, and they're all like, hey, podiatrists can do total ankles now and tibial nails because they were just banded together well, and they funded themselves well, and now they're lobbying well for themselves. So part of it is just recognizing the importance of this, and if you're not the one going to DC, then just donate to the PAC.
Yeah.
Donate to the ortho PAC because it's still going to benefit you in the long run. Part of it is depending on your practice model. My group hates when it's a vacation day for me to go down to Washington, D.C., right? There's no value for my group. They don't see any value in that. I see personal value, but it's not something that's good theoretically for my private practice model. So either you say, I like it and I'm going to do it because I have an interest in it. You can get involved in a health policy fellowship if you're in Hip and Knee Society. Academy's got a whole bunch of stuff that you can get involved in. Again, there's the state level. If that's something you want to do that's fun for you, great. If not, support the other people who are going to go do that for you because it's still going to have downstream benefit to you. And the other piece, just to digress a little bit about patient care and to go back, not just the advocacy piece, but I'm a surgeon. Send that back pain to the so-and-so, right? I don't want to deal with that obesity discussion. No, that's the whole point of driving the boat in musculoskeletal care is you may employ people or you may partner with people, with your physical therapist, with primary care physicians, but you can't just be like, I'm a surgeon. That's what I do. I do lumbar decompressions and I'm backing out of the other game. If we want to drive the boat, you have to understand that you're responsible for the musculoskeletal health of those patients, and we are the experts of musculoskeletal health. And you still got to at least be involved enough and care enough about that whole continuum of care. It may not be that you're doing it all, but just changing your mindset of, I'm a hand surgeon, I do hand. I'm a knee surgeon, I do knee. No, I'm an orthopedic surgeon who manages that leg for a long time.
Yep. Brad, I'm going to get you in a minute, but Dan, I just want to ask you, does this sort of concept of, population health management beyond sort of procedural based approach, does that come up sort of in the private equity space? Yeah.
Well, it's not just private. I
know. I know. I'm sorry. I shouldn't label you like that. Sorry.
But I agree. I agree with Brian. This war moving forward will be one on data analytics and care coordination. Yeah. So when you go in and talk to your payers, they talk like they have this much data on you. They really don't. You guys have lived this world. The war is also around Medicare Advantage lives. So our largest Medicare Advantage owners now, as of last week, by the way, are Optum. Optum owns United Healthcare. They're one of the largest primary care roll-ups in the country, if not the largest at this point. Oak Street Health, if no one saw the announcement, just got bought by CVS for $10 billion. They're one of the largest primary care roll-ups in the country. Walgreens owns Village MD, one of the largest primary care roll-ups in the country. So the private equity thing is here, and that's a discussion to be had. But the bigger discussion here is if you're not at the table, you're on the menu as a specialist because your Medicare Advantage lives are being owned and operated by other folks. So you have a vested opportunity and obligation around care coordination and data to be a part of these discussions, private equity aside. I mean, that's a whole nother conversation. But the challenge I have with most of the physicians I work with, because we do value-based care builds, is managing physician mentality around care coordination and then having everybody report data that is actionable. Because Dr. A, Dr. B, Dr. C, and Dr. D cannot be doing 4 totally different things or you will lose.
Yeah. No, it's great. Brad.
Yeah, just
Rich.
super quick. I've always wondered this. I mean, does this bundling get easier for the Kaiser Permanentes or the UPMCs where they literally have covered lives as well?
Yeah, I think it's a great point. Like who's most nimble to sort of like get into this sort of space. I would say like at Duke we're not that nimble, but we're trying to do it. So I guess I would throw it out that like probably anybody could do it. I mean, and meaning that like I don't know that it matters how big the practice is but I don't know I mean I don't, you could probably do this on your own, I would think.
Our group is not nimble at this.
Okay, well there you go. Real answer.
Well, I mean, none of the guys in my group I think are even talking about this yet. I think we're trying to figure out what is our next contract percentage bump.
Right.
Yeah.
Like, we're not even talking about like what if I own Central New Jersey.
Yeah.
I don't think.
Rich, go ahead.
So I've been, ever since we've been talking about this for,
Don't worry, people are going to still break
now.
the bones. It's okay to, you're fine.
Well, so that was my question.
I know.
I've been trying to rack my brain around how is this going to look in my world of trauma, right? You can't fix stupid, right? It's not.
No.
So, because y'all are way smarter than me. Like, I don't know how that's going to fit in.
Yeah. No, I think there's obviously disease states, whatever diagnoses where this doesn't work. The problem is if you look at just say like hip OA, knee OA, and shoulder OA, and then like start figuring out what that is of the total Medicare spend per year, like they got to do something like this, right? It's not necessarily a hip fracture or,
Trauma, like fragility care, right?
Yeah.
Post-continuum care for fragility care. A patient breaks their hip. You know what's going to happen to the other hip, right? So part of that is going to be, are we actually participating in that continuum of care for that fragility fracture patient, right? Or as you know about trauma, you can't fix stupid. That trauma patient always has lots of traumas, right? Like trauma's a disease. So you do have a
Yeah, and so Rich, we know you put a Profi cable on the other hip anyway, so when you fix the first hip, so kidding. All right, KP, you got a question in the back.
Yeah, I guess this is going to go towards the own-to-bone theory where, if after the person has a fracture, you're going to have to work with the primary care specialist with, checking the vitamin D, the calcium, getting them on some type of, bisphosphonate or something like that. I think that's probably where it's going to head to for trauma,
Yeah, I think the issue, I guess I would say is like, I think for literally, if you go right now to one of your payers and you say you want to do something like this, again, which I showed you we've done, like they have interest, but they need you to help them set it up. So like that's the dirty secret, right? Like you have the say whether it's trauma management, non-operative management for osteoporosis. Like you could go do it. I mean, you could. I mean, that's where it is right now because I'm sure some payers have a different level of experience, expertise, knowledge. But like literally, we set the one up. I mean, that's sort of it's our data. And it's again 3 diagnoses. It's not all of musculoskeletal care, right? But it's I think that's where it's probably going to go. It's not that hard to do it outside of hip, knee, and shoulder, right?
It plays out in every specialty.
Yeah,
Right? It's sports. It's ACL injury
Yep,
prevention.
that's right. Absolutely.
It's in every specialty. That it's just a matter of making sure that we stay involved rather than farming it out.
Yep, 100%. All right. Any other questions? Yes. Go ahead. Go ahead, Jess.
Logistically, so setting up some sort of musculoskeletal total care, are you able to, is it sustainable with the physical therapist, their appointments, before you have this contract?
Yeah, so it's a great question, and I'm going to try to be really honest about it. We have a system in place. I think we have up now to 27 PT providers, so multiple, locations in sort of our area of the state. I think I showed a slide that said they've had 7,000 visits, but that effort started probably, in all honesty, 6 or 7 years ago. And so, yeah, I think the cost structure is appropriate based sort of about what, who the providers are and sort of what the reimbursements are for those visits. But I can take no credit for this. Again, Bill Juranic, Chad Mather, and others, the effort they put into creating that was not insignificant. So, it's a great question. I mean, I think you can do it, but it's a lot of work and it's a lot of folks. I don't know. Do you guys any experience with sort of that approach at all for you guys? Maybe we're just dumb, I guess. I don't know, but no. Yeah, it's real. Now, I will say it doesn't have to be like our model. Like our model is to use the physical therapist, as the provider. I think you could do it, with others. Like it could be a PA, it could be another non-operative orthopedist or whatever. But
you guys are still managing the risk for the therapist, right?
Correct.
There are some people that are trying to align themselves with the physical therapist, and they own the risks.
Absolutely. It's a great point. Yeah, no. So that is, so it does depend about sort of the payment structure and sort of like who's in charge of the Department of Physical Therapy. But yeah, we take that risk on for us. So, and when we go into this, I showed you the one pair model that's been proposed. The goal will be probably the initial visit is with a physician, but then if they're non-operative care, it would be through what, again, we call the joint health program. So, any other questions?
Can I put a plug?
Yeah, please. Let's go, Meg. Let's hear it.
All right, so just because we talked about the PAC a little bit.
Yes,
so the PAC is a political action committee. What it is a fund that's used to help support lobbying for what we want to do for orthopedics. And so a lot of people say, well, I don't agree with what AOS is doing, or I don't agree with what this, so I don't want to give money. Well, the lawyers are giving 98% of lawyers in the country are providing to their PAC. So then probably 97% of the Congress is lawyers or something like that. So they also, they're thinking that way. And so the only way to get someone heard is, unfortunately, in our country, is through money. And so if they say, well, only 35%, you only represent 35% of the orthopedic surgeons, so why should we listen to you? What about the other 70%? And so really, even if you give $1, you're part of that percentage point. So you really don't have to give a lot of money. And what that does is that says to Congress, well, we have 75% of orthopedic surgeons support us, and we're trying to do this. And so then that's going to speak a lot louder than 35%. And so in order to get things going, you need to have that support and that percentage support behind you.
Yeah, Megan, do you mind just also speaking? I mean, so obviously I won't put you on the spot here, but I'm sure you contribute to the Ortho PAC. But I mean, there are obviously other opportunities to support, right? So local events, and can you speak to that at all?
Yeah.
But,
what do you mean by it?
Well, if you host,
So there's different levels of support. So as one person, you can just provide, $1 or whatever much you want to do. Then you also have Capital Club, which is, if you're a resident, it's $100. If you're faculty, then it's $1,000, and that's $1,000 per year. And so then you become that point person whenever there's a local event that they contact you and say, hey, here's like what our contribution, and then you can go and sit at the table with that congressman. And so,
but specify they give you a check.
They give you a check to go. So really, what happens is they give you a check, and you go and you support that congressman, and so that's how you get the seat at the table.
Give them the check.
Yeah, you give them the check.
You give them the check.
No, but
Specifically.
it seems shady. It really seems shady because you have money and you're like, here's money, talk to me. But that's really, I mean, that's how it is. My congressman in Connecticut was on the Ways and Means Committee, and so they were constantly giving me checks to go talk to him. And so I would go, we'd give like however much it was. And then I'd talk to him for 5 minutes. I'd have his ear for 5 minutes, and so, but that's the way
big.
that it was. And so, and then whenever I was advocacy fellow, I went for a week, and it's just going to meeting after meeting after meeting after meeting, and all of those were paid. and that money comes from the PAC, and that's how you get that seat at the table.
But as you're giving money to those people,
yes,
they also you're giving money in support of them because they're also back supporting you,
Correct.
Right? So when
Correct.
we're pushing through these advocacy efforts, we go to like Senator Barrasso or these people who are physicians or people who are invested in medicine, and because you've been supporting them, you have their ear, and you have the ability to push an effort further up the chain that would not necessarily have people signing on to the bill without you having been in their good graces throughout that process.
Yes.
Yeah, and I think for the group, just to explain, maybe Culp, I'll have you comment, but maybe Megan as well. Like percentage of times you're on the Hill that you see the senator or the congressperson or their staff.
I've been there twice. I've only met the staff people.
Okay.
I don't actually think I've met. Like I don't even know if they're like the people that report to someone that then reports to that person.
Yeah,
but you know what? Actually, you've met a couple of the same staff members a couple times in a row, and you actually start to know the staffers.
Yep.
So
who are the ones who know about
and they're the ones who are actually getting through to that person, unfortunately.
Yeah, and I think maybe Megan comment, like the staffer goes to the elected person and sort of a little bit tells them sort of what they should be thinking about.
Yeah, so there's something called a legislative aide, and they are the ones who know about specifics. So you have a senior LA, and then you have junior ones, and each one has their own focus. So a lot of times we'll be seeing the healthcare legislative aide, and so they know everything about everything that's going on in DC about healthcare. And so they actually can, not only can you talk to them about stuff, but they can provide you a pulse of what's going on in healthcare versus you go, it's nice to talk and take pictures with the congressman, but they usually, unless they're writing the bill or they're co-sponsor, they don't know a lot about it. And so it's actually really interesting because it also depends on the state that you're in. And so, like in Connecticut, I think I never met a single one in like 4 years. And then in Kansas, every single one of them came in because we had Senator Marshall. And so it was, it depends on your state as to who, but it really doesn't matter if you actually meet the congressman because the person who's actually helping make those decisions is the legislative aide, and that's probably more important to talk to.
And even if you're not going to continue to do this long term, it's good to go once. Because there's a lot of people doing this for you who they're going way more frequently than I go, but at least I know how much work is going into that on my behalf, because a lot of times you say, what is Academy doing, right? Or what is AUKUS doing? There's a lot of stuff they're doing behind the scenes, and just you going and seeing it once is probably enough to at least respect that effort going on behind the scenes.
That's good. Thanks for this panel. Give them a round.
Thank you again for listening in. We hope you enjoyed the discussion with our FPA faculty. If you'd like to learn more about our mission or upcoming events, please visit our website at www.buildingasuccessfulpractice.org.